Hello, everyone. Welcome to the webinar, Pain Management and Palliative Care. Our webinar will begin at 12 p.m. sharp. Please take these last minutes to get settled and get ready to enjoy the webinar. Can the panelists please turn their cameras on? Thank you. Hello, everyone, and welcome to our webinar, Pain Management and Palliative Care. My name is Joy Stokes, and I am the Communications Coordinator at Coastal Hospice. Welcome to our Caregiver Academy. We are excited that you're joining us today. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues from Tidal Health, the Holly Center, Home Instead, University of Maryland, Holloway Funeral Home, Wacomico County Public Schools, Compass Regional, MAC, Delaware Hospice, Compass Hospice, University of Alaska, and many more. Before we begin, allow me to go over a few housekeeping items. You may see myself or my colleague Alejandra pop up in the chat box to address or help with any technical issues. I want to thank you for your patience ahead of time, should we have any. I'll also come back in at the end to discuss the program evaluation. Our webinar today will be moderated by Monica Escalante, President of Coastal Hospice, and we have invited 3 experts on pain management to join us. Monica has more than 20 years of experience in end-of-life care. She is board member of the Hospice Network of Maryland and a diversity advisory board member of the National Hospice and Palliative Care Organization. Monica, I'll hand it off to you.
Thank you so much, Joy. Delighted to be here with such a good audience that is a national audience. We have people from Alaska, Virginia, Delaware. It's wonderful to have you all in attendance today. And our topic is pain management in palliative care. And it's my pleasure to introduce my panel. And I'm going to start with Dr. Willem Warwick. Dr. Willem Warwick is a hospice and palliative care certified physician with more than 30 years of experience. He graduated with honors and holds certifications in internal medicine, geriatric medicine, and hospice and palliative care medicine. He taught at the University of Maryland Eastern Shore, at the New Rochelle College in New York, at Eastern Shore Health Education Center, and at the Midwestern University Malcolm X College. He was awarded the Elaine Peterson Award by the Holly Center in 2001. Glad to have you here with us, Dr. Warwick.
Thank you.
Our second panelist is Dr. Don D'Aquila. Dr. Don D'Aquila earned his doctorate of pharmacy from the University of Maryland, where he completed specialized training in management, palliative care, and hospice pharmacotherapy, now specializing in palliative care and pain management services. He also provides pharmacy consulting for Talbot Hospice Foundation and teaches at Salisbury University and the University of Maryland Eastern Shore. Glad to have you with us, Don. Thank you for being here today. And last, we have Ann Lovely, and I personally consider Ann Lovely one of the most knowledgeable nurses when it comes to hospice and palliative care. Ann Lovely has over 23 years of experience, hospice experience. She holds a bachelor's degree in nursing and is certified in hospice and palliative care as a nurse. She has held diverse positions in hospice care, focusing on case management and education, and she is currently the Director of Quality and Education at Coastal Hospice. Thank you so much, Ann, for being here with us.
Thank you.
We're going to go quickly through the objectives for today's presentation. The first one is to describe the neurobiology of pain and potential targets, to compare and contrast non-susceptive and neuropathic pain, to know the steps of analgesic management and different medications, including their side effects, and finally, to assess and provide effective interventions and follow-up. If the audience has any questions, we're going to be monitoring the chat box. We want this to be as interactive as possible, but we also have a lot of content to deliver to you. And I'm going to invite Ann to help us understand, what is pain, Ann?
Well, pain is what the patient perceives it to be. And sometimes healthcare workers could have predisposed ideas that cause barriers to pain control. And some of those barriers can be a poor assessment of the pain, fear that the patient may have addiction, or concern about the patient becoming tolerant with the medication. And we hope to clear up some of those barriers today with this education. Pain is the #1 concern for patients and their families. And there are many fears that patients have. And sometimes what I noticed is most families felt that medications would hasten death. And in fact, proper pain management makes the patient function better and then have improved quality of life. There are 3 general rules. Any symptoms that are as distressing as the patient says they are. And there should be discussions related to treatments and risk, benefits, alternatives. And we also need to keep in mind the patient's values, cultures, goals, and fears. And we want to make sure that we are doing what the patient is wishing for. There are many types of pain. Acute pain begins suddenly, and it usually is sharp in quality. And chronic pain is usually long-standing and it's persistent. Usually it's associated with a chronic condition, such as what we treat here at Coastal Hospice. And visceral pain, an example of visceral pain would be something like a tumor in the liver or pancreas. And then somatic pain would be something like a bone fracture, strained muscle, cuts, straight burns, or even joint pain. And then neuropathic pain would be nerve pain, including maybe a neuropathy related to shingles or diabetes, or maybe even nerve pain due to a spinal cord injury.
Thank you, Ann. And today we will talk about different interventions that you as clinicians can utilize to help the patients manage this pain. So Dr. Warris, what are the rules of thumb when it comes to pain? What do you say?
First of all, thanks for having me here today and discuss this important topic. So the rule of thumb, as Anne mentioned, there are different types of pain. So you have to know what the etiology of the pain is. When it comes to pain management, I think the number one and first most important thing that we as clinicians do is to, we have forgotten all this in this era of technology. Have take a good history. A good history and physical is always the first step, and which directs your management. So taking a good history, looking at the types of pain, what the etiology is, what their previous usage of pain management is very important. As you can see, not all pains are the same. As Anne mentioned, you can have a nociceptive pain, which would be divided into visceral and somatic. So depending on where the origin of the pain is, and we have access to all the records when we are seeing the patients, that also directs us towards the particular management. And not all the patients have same pain sensitivities. You will have a patient who you start with the low dose and will probably have more side effects than others who have history of chronic pain and would need higher doses. So that is also important. So the process of pain, there's a concept in palliative and hospice that you treat total pain. That means you just not only focus a physical part, you also focus on the emotional and spiritual part of the pain, because it also affects the management. And then you treat each type of pain individually. The most important part is not just to put somebody on a medication and not follow it. So the continual reassessment of the treatment goal is very important when it comes to pain management. It's also very important to find out the intensity, the duration of the pain, what makes it worse and better, and how it affects one's functional capacity. I had a patient in the palliative care clinic who loved to carve wooden structures and had a garage especially made for it. But his pain was so bad, he couldn't even get out of the garage. So when we started dealing with him, and he had lung cancer, and started controlling his pain, which was also spread to the bones, within a week or two, he was back in his garage. I mean, that was the most important part of his life. But with the pain so severe, he couldn't even get out of the house. So that's important. You have to look at, okay, what your goal is, and how is it affecting your function? And then you want to make sure that you don't give them too much pain medication that affect their function too. So we have, and we have to also address how bad is the pain. The intensity is very important. And if it's any pain which lasts more than 3 months, it becomes a chronic pain. And if the pain intensity is severe, I have seen patients in the clinic who come to clinic with the pain 10 out of 10, but were started on a short-acting oxycodone, 5 milligrams to take every 4 to 6 hours, and they are in severe pain. So if the pain severity is that high, the rule of thumb is to start them on a long-acting narcotic and then add a short-acting for breakthrough pain, and not wait till they get to the palliative care clinic. So those things are very important. And anytime someone is on a short-acting medication, and if they're taking more than 3 to 4 a day, they probably need a long-acting on top of it.
Yeah, pain management is a specialty that we at Coastal Hospice in palliative care, we know very well. Our Dr. Warris is mentioning the different strategies, but there's also required practice. You've been doing this and you do this day in and day out. And if one thing we're going to restate several times here is that if a patient is started on a long-acting medication, breakthrough medication is needed, right, Dr. Warris?
Yes, and then there's been so much regulation lately that, I was reading an article just 2 weeks ago that more than 60% of the cancer patients who have acute pain are now ending up in the emergency room because of the regulations. The primary care physicians or their PCPs are not starting them on pain medications. Now, we all have access to PDMD, which is the Precision Drug Monitoring Program. So it's also important to look at that when you're starting somebody on a narcotic to see if the patient, you always have outliers and you have to be careful. You have to be compassionate, but you also have to be vigilant when you start somebody on an opioid or a narcotic. So all those things are available to you. And just recently in Maryland, now the physicians won't be able to write any handwritten prescription. They all have to be electronic. And one of the reasons for that is that state wants to, or we all wants to know what patients are taking and if they're not doing window shopping with other physicians. So that's also important. And in the clinic, we also do a pain contract when we see a patient, and we do random drug screening. So it's always good to reassess and monitor.
Yep. Thank you, Dr. Warris. And can you help us with pain assessment? How do we do it in hospice?
Sure. Before we begin treating the pain, we want to make sure that we get a thorough pain assessment. And Dr. Juarez talked about, the pain characteristics and seeing the onset, the duration, the location, not only where it hurts, but is it radiating, the quality, intensity. But we also want to make sure that we use an appropriate pain scale. So when we are assessing the patient's pain, if they're able to use the numeric pain scale, of course, we would use that, but we may need to use smiley faces or the FLAC scale, which is staff observation. But there's also the pain ad scale, which is for dementia patients specifically, because they're unable to tell us what type of pain that they're having. We also want to think about pain terminology, because in some cultures it may be, make them feel less than perfect if they're not, if they call it pain. So they may want, you may want to call it hurt. Are you aching anywhere, instead of calling it pain, because that may seem that they are weak. Or think about children. What are their parents? Talk to them. How do they describe pain? Is it ow or ache, or how do they describe it? We also want to find out a good patient history, a pain history, what has worked good in the past and what is currently working for them. Don't always think that if someone is giving a recommendation of what's helped them in the past, that they are actually drug seeking or anything like that. They just really know what works best for them. And then we want to find out what kind of impact this has on their activities of daily living, or how is it affecting their quality of life? Is it, is it that they want to get up and go have dinner at the dining room? So, maybe we need to be giving them certain tasks with keeping a pain journal so that we can know how to treat that pain. And maybe when to give medication so that we know that we can get them to that dinner table at night. And then we also want to think about the patient's goals and the family's goals as well.
So, and there are nonverbal pain indicators that as clinicians we should pay attention to?
Yeah, so you want to look at facial expressions, and these might include grimacing, but we don't want to forget about things like rapid blinking or frowning or looking sad or frightened. Also with vocalization, there may be crying, of course, but take a look at moaning, or that person that is calling out or asking for help. And of course, with body movement, sometimes we know about guarding, but maybe it's that person that's fidgeting or rocking, or maybe if they're not wanting to move, because they know that it hurts when they do move.
Do you find that some clinicians, when we see the patients all the time, caregivers, when we see the patients all the time, we might be less likely to see the changes?
Yeah. Sometimes that may be it. And sometimes if someone's maybe fidgeting, it may be thought that the person's maybe having some anxiety. So we don't want to forget about pain as well.
Yeah, that's why in hospice care it's important because our nurses go to the homes and they can see the changes from the last visit to the next and support the caregivers in that way.
Right.
So
Sometimes in the non-verbal patients, especially with dementia, intellectual disability, the pain is exhibited as increased behaviors and agitations. So, 20 to 30% of dementia patients some have chronic pain that if we don't address, they exhibit it as agitation. And instead of putting them on antipsychotics, we should also try non-opioid pain management.
Right. And sometimes with those nonverbal patients that are unable to tell you that they're having pain, sometimes I would talk to the doctors about maybe prescribing something as simple as Tylenol twice a day so that they're getting some type of pain relief when they're unable to tell us.
yeah. So the pain physiology, Dr. D'Aquila, help us with this one.
So I think Anne and Dr. Juarez did a wonderful job really explaining the pain assessment piece, which is extremely important, and also the underlying basics of pain approaches. So, when we're doing pain management for our patients, not only in the chronic and acute space, but more focused in the palliative and hospice space, it's usually an individualized approach. And to give that individualized approach, you have to understand the underlying physiology of how these medications we're going to discuss work in the body. So quick overview here. So we do have opioid receptors in the body where medications will bind and they will have an effect of analgesic. Typical receptors that we see are mu, kappa, delta. Those are the three prominent opioid receptors. And we'll talk about how the medications work on each receptor specifically and why that might tell us which medications might be better than others. It's also important to describe that ongoing exposure to these pain medications, specifically opioids, will cause a level of tolerance. Unfortunately, sometimes caregivers, family members, patients, even providers may interpret tolerance as a form of diversion or addiction and can become a barrier. But from a physiological standpoint, if a patient is on these medications for an extended period of time, any patient will develop a level of tolerance where the specific dose that the patient is on may not be as effective as it was in the beginning. So what do we do when that happens? So identifying tolerance and implementing appropriate approaches to help mitigate those barriers and issues we may see. Once again, it's individualized. Every patient's going to be a little bit different. You have to determine what the underlying considerations are, looking at patient demographics such as age, renal function, liver impairment, what they've used before, and what might be the best approach moving forward. And some historical thoughts, there appears to be no limit to the development of tolerance. And with appropriate dose adjustments, patients can continue to obtain pain relief. And, what I've seen historically in practice, especially when the opioid epidemic hit, we saw patients that were maintained on the same types of medications for an extended period of time. And typically what that leads to is patients being on very high doses of opioid medications. And usually you don't see the same efficacy as you did at the beginning. And that's a physiological response. So as clinicians and caregivers, we have to understand what that physiological process is and what do we do to make the outcomes better. And typically opioid rotations are a very effective approach to mitigate those issues. And we'll talk a little bit more later on about how that's done.
Yep. Thank you. Dr. Juarez, what are pain management approaches that we have? Palliative care versus hospice care?
Yeah, so there's a misconception and a lot of people don't know the difference between palliative and hospice. So I'm going to go a little bit over this. And so the palliative care is a specialty, and it really starts at the beginning or establishment of a chronic diagnosis, and including cancer, COPD, dementia, all chronic diagnosis, Parkinson's, Huntington's disease. So, and it involves symptom management. So it's also an interdisciplinary approach, and we treat all symptoms, including pain. Pain is one of the major symptoms that people have with any chronic disease, especially cancer, and it continues. Now, when patient is at a point where the treatment is not curative, or they're not responding, or their functional status is going down, and two physicians determine that their life expectancy is 6 months or less, then they are eligible to hospice and usually are moved to hospice care. Now, the palliative care does not stop with hospice, because palliative care means symptom management. So it continues till the end.
Thank you, Dr. Wars. And for the audience to know that every year at Coastal Hospice, we graduate about 100 patients from our care, not because they are cured, but because their care is so well managed, they are no longer on a downward trend.
Yeah, we see that all the time. We have patients who get admitted to hospice, but when we manage their symptoms and we address polypharmacy and de-prescribe things that make them even worse, they get better, and then we have to graduate them.
Yeah.
Yeah, I also think it's important to remember, what are barriers to therapy? And, when we look at opioid regulations in the palliative care space, we still encounter all these regulations and loopholes that we have to jump through. And, hospice, I like to describe it as a nice little bubble where things just become easier. So, in my clinical practice, one of the things that I promote, sometimes patients that are qualified for hospice may be reluctant to go on to hospice just because of the perception of what hospice means. So, we are certainly educating that, hospice does not mean that you're coming on hospice to die. And actually, a lot of times when patients transition over to hospice earlier, when it comes to symptom management, they would probably have a prolonged lifespan in some instances, and they're able to obtain the appropriate resources, especially with pharmacotherapy, a little bit easier to achieve those pain management and functional goals.
Thank you. Thank you for that. Dr. D'Aquila, turn to you, opioids.
Yep. So we'll discuss the pharmacotherapy behind pain management. Maximized medical management, what I refer to is the utilization of medications to achieve pain and functional goals. And, these are the most common tools that we have in our toolbox to achieve those goals. So opioids, they still play a prominent role in allowing us as clinicians to achieve those patient goals. And the most common ones that we see and that we'll discuss: morphine, hydromorphone, transdermal fentanyl, oxycodone, and methadone. So, some of the most common ones, morphine, hydromorphone, we see a lot in clinical practice. Just touching on the physiology briefly, how do these medications work in the body? Morphine and hydromorphone specifically work on the mu receptor, so one opioid receptor. Hydromorphone is a bit more potent than morphine. When it comes to the treatment of pain and dyspnea, morphine does have a lot of literature to back the utilization and may be considered the gold standard. And also, when we're discussing how to manage these patients individually, sometimes we encounter barriers regarding the administration. We may have a complex cancer patient. We may also have a patient that has dysphagia. So knowing how the medications, what formulations they come in, is also an important factor. Are we going to be able to administer the medication in a tablet form? Is it going to be parenteral, or subcutaneous? Do we have a liquid concentrate? So it's important to know how the medications come. Both morphine and hydromorphone, of course, come as tablets and IV formulations, and they also come as a liquid option available too for patients.
I'll tell you, Don, I've had patients who've had fear of getting the morphine at the end of life because they were afraid that their loved one couldn't swallow. And sometimes helping the families actually see by, taking the dropper and showing them with water just this small amount of morphine that they get with what we dose them with sometimes helps them with that fear. So, we just always have to be educating on our medications.
And it's
Yeah.
also important, as a geriatrician, you always have to keep in mind, if you go low and go slow, you don't really see a lot of the side effects.
Yeah, I mean, morphine is associated with that, and I agree. And Dr. Juarez, I also agree with your point. Education is key. Educating our families on, what the goal is with what we're providing them. Studies show that utilizing low dose morphine will not suppress the respiratory drive in an opiate naive patient. So the goal here is never to hasten, it's never to sedate. Typically it is just to mitigate the symptoms that the patient is having. And we do that in an appropriate manner.
How about fentanyl and oxycodone?
So just to review, we talked about morphine, hydromorphone, working on the mu receptor. Fentanyl and oxycodone are a little bit different. Fentanyl works on mu and delta. Fentanyl can be beneficial because it has less active metabolites. It may be a beneficial approach in patients with renal disease. There are some drawbacks with fentanyl though, and specifically in clinical practice, we're talking about the patch is the most common one that we see utilized in the community. Studies show that geriatric patients have erratic absorption with the fentanyl patch. So patients aged greater than 75, we tend to see more side effects than efficacy when we push the dose a little bit higher with the fentanyl patch. Also, if our patient is skinny or cachectic, the medication typically is not absorbed and will just lead to side effects. So in much of our palliative and hospice population, there is a role for fentanyl patches, but it's most likely not our most go-to option. Also oxycodone. So, when we talk about potency of medications, morphine's the gold standard. We talked about hydromorphone being a little bit stronger. Fentanyl, of course, is a lot stronger. That's why it's dosed in micrograms versus milligrams. Oxycodone is also a little bit more potent than morphine, 1.5 to 2 times the potency. It works a little bit different on the receptor. So kappa and mu, morphine mu, hydromorphone mu, fentanyl, mu delta, oxycodone, mu kappa. One of the clinical benefits with oxycodone is it doesn't have a significant metabolite after it goes through the liver. So in our patients that have end-stage renal disease or end-stage liver disease, and especially in ones where we're trying to reserve cognition, oxycodone may be considered a more clean approach versus morphine in that patient population.
Few points about this fentanyl oxycodone. I personally really try to avoid fentanyl. I had a patient 2 weeks ago in the clinic that had 8 out of 10 pain, and the community physician put her on a 12.5 microgram of fentanyl, did not give him any breakthrough medications. Well, keep in mind, when you put the fentanyl patch on, it takes 72 hours to kick in. So the pain's not going to get better with the patch on. The other thing, what this patient did was he was having a local reaction to the patch. He kept on moving the patch from one arm to another arm. So that just really didn't do anything for him. So, that's a really good point. And then the patch can come off. And as Dan said, if somebody has a fever, the absorption increases. If they don't have enough muscle tissue or fat, then the absorption decreases. So you have to monitor clearly. The one point about oxycodone that I've seen in my practice is that people develop tolerance to it more faster than the other narcotics. So you have to keep going up and up on the dose. And so I usually, when I get to a point where they're using 4 or 5 a day, I usually rotate them to a different one, and hydromorphone works really good.
Yeah, I agree, Dr. Juarez. I think it's important to remember, especially the fentanyl, is with most long-acting opioids, you can't chase acute pain. So for somebody that's having escalating pain, more acute in nature, treating them with monotherapy long-acting opioid is not a good look. And specifically with the patch, it takes 72 hours to kick in. So when you throw that thing on, it's not having any sort of efficacy at all. So it's important to decipher acute versus chronic. and when to use short-acting medications more geared towards acute or breakthrough versus long-acting more geared towards that chronic requirement.
Thank you, Don. Now the methadone that I consider misunderstood methadone.
Yep. So methadone is a very important medication in the hospice and palliative space. There's a predisposed etiology, you know, with morphine. We talked about how patients or families may feel like it hastens things. With methadone, there's the perception that, hey, why are you putting my family member on methadone? They're not an addict. You know, methadone has multiple indications. It is an opioid like the other ones. It does have some special properties that make it a very good tool for us to have. So discussing the physiology, the opioid receptors, mu, delta, kappa, it works on all three. So it's a little bit different than the other ones. Plus it has other adjuvant mechanisms. It inhibits the reuptake of norepinephrine and serotonin. And it's also an NMDA receptor antagonist. And those are two important factors because it'll help manage neuropathic pain. We all know that neuropathic pain is a very difficult pain syndrome to manage, and methadone can be a very effective tool to help achieve those pain goals and functional goals for those patients with chronic neuropathic pain components. You know, the other really important thing here with methadone is it's the only long-acting opioid that comes in a liquid concentrate. So we discussed how it's important to decipher how you're going to administer medications. And especially towards end of life, you know, how are we going to get medications into a patient that has dysphagia? Methadone does come as a liquid concentrate, so it can be dropped in the buccal area, it can be dropped under the tongue, and very effective. It's absorbed in the blood vessels, bypasses what we refer to as first pass metabolism, goes directly to the brain, and it's very, very effective. It's almost similar to giving a medication IV. So, you know, for those patients that, you know, have the dysphagia, it's a very important tool. If you were to compare it to like a long-acting morphine, oxycodone, you know, those medications cannot be crushed, they cannot be split. Typically at end of life, you would have to administer those things rectally. And that can be very burdensome to the patient and the family. So methadone, very, very good for neuropathic pain syndromes. It's a very cost-effective medication and very important. It's the only long-acting opioid that comes in a liquid concentrate that can be administered sublingually.
Word of caution with methadone that I've seen in my practice, you know, now methadone is being used more and more for chronic pain. You know, even musculoskeletal and rheumatologists are using it, but you really have to know the physiology. You have to monitor closely. I always start with a low dose, like 2.5 milligram twice a day. If somebody is having chronic pain, it's a really good drug for neuropathic pain and bone pain, the metastatic bone disease. It works. The one thing that I have seen a few times is that, you know, it's a long-acting drug. It should not be used as needed, like for a breakthrough pain. I had a patient a few months ago who was on methadone 5 milligram every 6 hours as needed. So I had to sit down with him and look at his diary to how often he was taking. It does have a cumulative effect. So you can't really just put somebody on as needed. It's a twice a day drug, sometimes can be used 3 times a day. But you know, you have to monitor and keep in mind it does have it can increase the QT prolongation. So if somebody who has a QT syndrome and have cardiac arrhythmias, you need to monitor that. So yeah, never use that as an as needed or a breakthrough drug.
Yep, and there's actually data to back up what Dr. Juarez is saying. If you look at the CDC data with overdoses, methadone is typically higher than the rest, and that's associated to prescriptions given by primary care providers for the indication of musculoskeletal pain. So the perception here is that methadone has complex kinetics, and you really need a specialist to help initiate and manage this medication. And at Coastal Hospice, we have those expert clinicians to help guide those types of therapies. So this can be a great medication for many patients with chronic pain, but you do have to take special considerations.
Yes. I mean, you're going to share our emails and all that at the end of the thing. So if anybody has a question, shoot us an email.
Yep. And if you have a burning question, you can use the chat box right now, which we are also monitoring. So duration, long-acting versus short-acting medication. Dr. Warren?
Yeah, so as we discussed, there are long-acting medications. So anybody who has chronic pain, which is not controlled, should be on a long-acting drug, which is usually given twice a day. In fentanyl, it's given every 72 hours, you change the patch. And then when they have chronic pain, they also have spikes of breakthrough pain that, in between. And I tell you the truth, the etiology of breakthrough pain is usually unclear, sometimes have no etiology, but people who have chronic pain will have a spike in the pain. And then the long-acting drugs is being taken twice a day, so you cannot do anything with that. So when they have a breakthrough pain, you can use a short-acting drug like oxycodone, hydromorphone.
Yes.
And when I would have patients keep journals, more so because we want to see how often they're having to use breakthrough pain medication. And if they're having to use breakthrough pain medication more than 2 or 3 times a day, that's when you want to notify that physician so that we can talk about maybe getting an increase on the long acting.
Yeah, that's a very good point.
Yep. And we have the audience a question. How are you able to manage patient pain in an outpatient setting?
So yeah, that's why we have an outpatient clinic and palliative care clinic 5 days a week that we are seeing patients and communicating with them. So when we see the patients as an outpatient, we do a good history and physical and assessment, and then do a pain contract so they can only be seen with one physician, because by going to different physicians, first of all, the chances of polypharmacy is bad, and then their pain is not managed well. So we follow them, and they can call us back. Every time I see a new patient, I ask them to call us within a week, and sometimes we see them twice a month. So that's how we manage.
Yep, and there's another question from the audience asking if we're going to share the PowerPoint with you, and absolutely, yes, we will. And you will have emails of our panelists to reach out in case there are questions. Dr. D'Aquila, tell us about the opioid side effects.
Yeah, so real quick, we talked about the underlying physiology, and we have to remember that these medications work differently within the body. And, different medications may be associated with a different level of risk. The typical opioid side effects that we worry about, of course, respiratory suppression, altered mentation, lethargy. The other one that we're concerned about is opioid-induced neurotoxicity, which really isn't a common thing if it's managed appropriately. Morphine has a metabolite that is very lipophilic. It can cross the blood-brain barrier. So for those patients where you're escalating doses very aggressively, very fast, high dose, or if they have underlying, renal dysfunction, liver dysfunction, or other concomitant medications that may interact, we may see that opioid-induced neurotoxicity, and morphine really has the highest risk associated with that. So, going low, starting low and going slow, as Dr. Juarez said, really should be the approach here. And, the biggest thing that we should really be looking at is constipation. It goes hand in hand. Whenever we're starting patients on opioid medications, unfortunately, we have opioid receptors in the GI tract, and not clear what the indication for those receptor sites are, but the medications will bind to those receptor sites and slow GI motility. So hand in hand, when we start a patient on an opioid, we should also start them on a laxative. Typically, a little gentle stimulation is the way to go. So Senna will be your drug of choice for that.
Yeah, and I had a teacher who, when I was doing some training at palliative care, used to say that the hand that writes a narcotic, if it doesn't write a laxative, that hand will be disinfecting the patient in the ER. So always remember to add a laxative, and it could be, and I would stay away from Docosate, which is a stool softener, but it doesn't stimulate and push the stool out. So my preferred is Pericolase, which is, which is like combination of Docosate and Senna. So Docosate will soften and Senna will push. Dalcolax or, Miralax, things like that. The stimulant is better than just the stool softener.
Thank you. Anne, do you want to add anything to this that you see in the hospice setting?
Yeah, I would also tell patients to make sure that they're keeping track of their bowel movements, how often they're having them, because anytime that they went more than 3 days or 3 days or more, that's when we would really try other interventions.
Thank you. Dr. D'Aquila?
So the general gist and the overall premise of this slide is that we don't just pick these doses out of the air. Once again, it's an individualized approach. And, how do you implement opioid strategies? How do you initiate long-acting approaches? When it comes to methadone, we discuss the complicated kinetics of the medication. So this is a dosing table that's typically used when we're talking about opioid rotations or initiation of long-acting pain medications. The first step is typically always to calculate the morphine equivalence in a 24-hour period. And that'll give you your base on how to convert utilizing equal analgesic potency guidelines. And then there's guidance on how to initiate long-acting approaches. So we're not going to get into the nitty-gritty and examples here, but the general perception is that it should be an individualized approach, and there's tools out there that we can utilize and leverage to make sure we're doing these things safely. And once again, engaging with a team that has expert clinicians that understand the complications of these medications will really benefit the patients and the overall outcomes.
Yeah, the way I do it, Dan, is very simple. You calculate the last 24-hour dose of a drug, and when you're rotating to it. And if you're not sure, always consult a clinical pharmacist. There is a clinical pharmacist at the hospital. There is a pharmacist and they will tell you what the dose is. But when you calculate those and you're converting from one to another, yeah. Remember, when you're converting, you still have the metabolites, you still have that previous drug in the blood. So always, whatever number you comes up with it conversion, cut down 50%. So you always cut down 25 to 50% of the new drug, and then start and then go up accordingly.
Absolutely, I completely agree. When we're doing these calculations, when you develop the plan for the new opioid, I always reduce it by 50% to start with. That's a great approach.
Yeah, we're sharing wonderful tools for our audience today. So breakthrough medication, Dr. Worse, you talk a lot about this.
Yeah, so it's very important because, as I said, people with chronic pain will have a breakthrough pain, or they will have incidental pain, like when you're going somewhere or we're doing some activity, they'll have pain. Or if they have dementia or they're bedbound, you're doing some care, then they will have pain. So those need to be addressed. Anybody who's on long-acting medication should be on a short-acting opioid for breakthrough pain, and it's usually a 50 to 100% of the long-acting. As Anne mentioned, anytime somebody is taking 3 to 4 short-acting drugs in the last 24 hours, we need to look at their long-acting medication and increase it by 10%.
I think it's important to remember the issue of tolerance here. And I see it a lot in clinical practice. Patients who are on long-acting opioids, a lot of the time aren't on sufficient short-acting breakthrough management. So we have to remember that the tolerance makes a difference. So 10 to 20% of that total daily dose of that long-acting medication should be initiated in a short-acting option. I might see a patient that's on methadone 10 milligrams twice a day, but they still have 5 milligrams of morphine in a comfort pack. Based on the amount of requirements and the level of tolerance of the methadone, that morphine dose typically would not be sufficient. So we have to take into consideration level of tolerance, when we're working with long-acting opioids, how high is the dose, and are we utilizing appropriate short-acting opioid doses for breakthrough management?
Dr. Boris, do you see that some patients that are referred to you could have used breakthrough pain medication when they are on a long-acting?
Yes, we see it all the time. People get started on morphine or methadone or a fentanyl patch, and then what are they taking is in between Tylenol and Motrin, which doesn't really help for these type of pain, especially cancer pain. You see it all the time. So yeah, anytime you start somebody on a long-acting medication, you should also have a breakthrough added to it. And another point is, I've seen it, I see it all the time. Somebody's on 5 milligram of oxycodone, on 2 milligram of Dilaudid, and they have a breakthrough pain, which is 10 out of 10, and they use one dose, and the next dose is ordered every 6 hours. Well, the effect lasts sometimes 30 minutes, usually 3 to 4 hours, the effect is gone, but the pain is 10 out of 10, you can tell them to use another dose within an hour.
Yeah.
That prevents an emergency room visit most of the time.
And for the audience, some of these things are not written on our PowerPoint that we're going to share, but we're also going to share the recording of this webinar so you can watch it again or share it with other colleagues as you may see necessary. So what are yours, Don?
Yeah, Monica, one more thing, one more point about breakthrough management. I see sometimes clinicians titrating long-acting opioids blindly, what I refer to it as. The other benefit of having appropriate breakthrough approaches, when we consult with the bedside nursing staff, as a clinician, the first thing we're going to ask, what's the breakthrough requirement been in the past 24 hours? And that allows us to gauge a safe approach on how to titrate the long-acting medication, because if you titrate it inappropriately in the long-acting form, if you do develop a side effect, those side effects are going to last much longer. So not only does the short-acting breakthrough allow us to achieve those pain goals, but also allows us to titrate that long-acting approach effectively and safely.
Yeah, the another good point that I usually do, you're talking about inpatient, you can go to the nurse and look at the record and see how many are giving, but as an outpatient, I tell my patients to keep a diary of all the medications they're taking. So when they come to the clinic, I review that and then discuss with them. I've also seen sometimes, especially the MS-Contin or methadone, there are, some of us are, what do you call them, fast metabolizer through the liver. So the long-acting drug, which is twice a day, usually doesn't last, or it lasts for 7 to 8 hours. In situations like this, I switch them to every 8-hour MS-Contin or methadone. Yeah. Instead of keep giving them short-acting medications.
Yeah. Thank you for sharing such good strategies. So what are the factors in determining treatment? Dr. Boris, what would you say?
Yeah, so as we said, all these medications pass through the clearance, and age is very important, because when you become older and 65 and above, your renal function and your renal clearance it decreases due to age. So you have to keep in mind which medication is. So methadone is bimodal. It's a very good drug because it can be used in the liver and kidney, especially people with end-stage renal disease. Methadone is my drug of choice. And I usually tell them to take it after the dialysis, and it lasts longer. But you should clearly stay away from morphine if people have chronic kidney disease or renal function is decreased. And it's also very important to ask patients what they tried before and what worked and what didn't work. Yep. History is very important.
Dr. D'Aquila, what are administration thoughts? What factors do we consider when we choose how to administer the medication?
Yeah, I think we touched on this, but it's important to remember, how are we going to administer these medications? Does the patient have dysphagia? Do they have a GI obstruction? What complications are going to make administration more complicated? We leverage the sublingual type approach in the hospice and palliative space. One, we talked about why that's beneficial from a first pass metabolism. It bypasses that, goes directly to the brain, and it's very fast acting, similar to IV approaches. And it can also allow us to administer those medications in somebody who can't swallow or somebody who's end of life. And when we're doing the sublingual approach, we want to keep the volume at 1 ml or less. So those liquid concentrated drugs like morphine or methadone, that's why they're so important for our patient population. We discussed the transdermal issue with patients and fentanyl patches. They have to have adequate subcutaneous tissue for the medication to be absorbed. At our inpatient setting, Coastal Hospice at the Lake, we may leverage the subcutaneous approach. This is similar to IV, but it's less invasive and more comfortable for the patient. When we're giving medications through the subcutaneous line, we have to keep the volume less than 2 mLs typically, so we don't lose the line, and also intravenously through a PCA. So not only are medication strategies very important, but how do we administer them? And leveraging the expertise of the clinical team on how to best effectively get the medication into the patient to achieve those goals is very important.
Yeah, and another point is, there are patients who have head and neck cancer or esophageal cancer or patient with cerebral palsy. You have a PEG tube or a G tube. And for that, morphine and methadone are excellent liquid drugs. So you don't have to crush, you don't clog the tube. You can just keep in mind, I always tell my patients, once you push the medication, you may want to flush it because otherwise it'll stay in the tube and you won't have any effects. So always use a 30 ml flush after PEG tube administration of morphine or methadone.
So other therapies, Dr. D'Aquila?
Yep, so when we talk about pain management, of course, we discussed opioids, one of the mainstays of achieving our pain goals. But we also talk about multimodal techniques, especially in the chronic pain space. It's a very hot verbiage right now, multimodal, which includes more interventional techniques, non-pharmacological techniques, and also non-opioid pain modalities. So other medications that are not opioids that will affect pain pathways and help us achieve those goals. We discussed methadone with neuropathic components. Some other tools that we have are gabapentin, the neuromodulators, also including Lyrica, and some of the antidepressants. Bone pain can be very, very difficult to manage. And a lot of times opioids as a monotherapy won't allow you to achieve those goals. So adding on a steroid or NSAIDs can be risky in patients with GI issues or renal issues, or if they're old. So there are some drawbacks to that. Steroids specifically can be great for patients with metastatic disease to the bone or to the spine. My typical recommendation is dexamethasone. There's also prednisone. I like dexamethasone because it's more lipophilic. It penetrates the tissue a little bit better. It's longer acting. And it also has less mineralocorticoid activity, so less risk of fluid accumulation. And then spasticity. So we have muscle relaxers or benzodiazepines also in our toolbox to achieve those goals.
Yep. And Anne, can you talk to us about non-pharmacological approaches we take?
Yeah, so we talked about the medications that we can try to help a patient reach pain control. However, there are many non-pharmacological approaches. And here in this picture on the slide, you can see Doris Ludicky, who is one of our music therapists, and she's playing the harp. And I have seen how music therapy can truly help with a patient's symptoms, as well as counseling and heat or even ice, thinking outside of medications, we really could get pain control. But distraction, just sitting there, maybe doing something with the patient, talking with the patient, distracting them from their pain, maybe even allowing the pain medication that they've taken to work, really does wonders for our patients.
Yep. And we also have other modalities like pet therapy.
Yes.
Acupuncture, well, we don't have that.
Yeah, they would have to go see someone for that. Yeah.
Yeah. And we are 4 minutes away from the end of our webinar. I'm just going to turn to the final comments that we have here. Our goal is comfort care. Dr. Warris, final thoughts on this?
Yeah, so the goal is comfort. At least, 60% of cancer patients have chronic pain, and 30% of them is moderate to severe pain. As I said, a lot of patients are not getting adequate pain control because of the regulations that have brought up. But we have to be compassionate, we have to be vigilant, and we have to make sure patients have good quality of life, especially at the end of life when the pain, it can become a distressing symptom with worsening the quality of life. So symptom management is very important, and palliative care can always help you. It's available inpatient and outpatient for all cancer patients and other chronic diagnoses. But by controlling symptoms, you are avoiding inappropriate prolongation of time. That is poor quality of life when patients die in pain. And it gives them the sense of control, because when the pain is controlled, their symptoms are better, their quality of life improves. They can do things they enjoy. They can have better time with their families. They can go out and have an ice cream, on a good day, things like that. And it relieves burden for not just the patient, but all the family members that they have to go through that. You don't want a grandson remembering their grandfather dying in pain. Mm-hmm. It's distressing. So that's how we have a teamwork approach and with hospice and palliative care. And it strengthens relationship with loved ones. Yeah. It's all about quality of life.
Yeah. Dr. D'Aquila, some final thoughts?
Yeah, I just think it's really amazing the team we can leverage in the hospice and palliative space. It's truly interdisciplinary. And, when we're discussing pain management, it's typically complicated, as Dr. Juarez says, and there's usually multiple different facets of what's actually going on with the patient. Maybe they have insomnia, maybe they're depressed, maybe they have anxiety, maybe there's a spiritual component. And as an interdisciplinary team, we have all the tools to leverage to take care of all the pieces of the puzzle and put them together and really find a sufficient plan for those comfort goals to really be achieved. So, in the community, when we work with community stakeholders and community providers, if they understand the tools that we bring to the table and how they can leverage our tools in achieving those patient goals, it's a really special thing. And at the end of the day, it really allows the care team, the patient, the family, all the loved ones to really have a good quality of life.
Thank you. And final thoughts?
I just want to mention that, the earlier we can get their pain under control, the better of quality life they have and the better quality they have to the end of the life with their families.
Thank you, Anne. Thank you. Thank you to this fabulous panel. Thank you to the audience that is typing. Thank you. Great presentation. Appreciate that. Everybody is going to receive a recording of this presentation and, of course, the PowerPoint if you need that as well. I'm going to turn it to Joy now.
Thank you to all of our panelists, Dr. Gulam Juarez, Dr. D'Aquila, and Ann Lovely for this presentation on a topic that may be relevant for many. And thank you to everyone who has joined us today. We hope the information was useful to you. To wrap things up, we ask you to take a couple of minutes to fill out this short survey. It is only a few simple questions. Your feedback will help us bring relevant programs to you, your practice, and those you care for. When you click Leave the Meeting, you will receive a survey from Zoom. Thank you once again for joining us. I'm Joy Stokes, and have a wonderful rest of your day.